Transversus Thoracic Plane Block for sternal pain control in cardiac surgery and surgery of the anterior chest. My name is Gabor. Patients can be positioned either supine or when the block is done awake with their head up to aid with respiratory status if needed. Description of block technique. In cardiac surgery, the block is usually performed after induction of general anesthesia. Follow the protocol of preparation for central venous catheter insertion. Wash hands and don sterile gown and gloves. Clean the area around the neck and the sternum and apply sterile fields. Apply sterile sheath to the ultrasound probe. Proceed to scanning for the transversus plane block and confirm anatomy. Under ultrasound guidance, perform the TTP block, then proceed to central venous catheter insertion. Here are the landmarks for the transversus thoracic plane block, which in this image is performed after cardiac surgery. A high-frequency linear ultrasound probe is placed on the chest in the parasagittal plane and medial to the mid-clavicular line over ribs 3 and 4 or 4 and 5. Identify the ribs. Identify the third or fourth rib space, the pectoralis major and the intercostal muscles and the pleura with the above transversus thoracic muscle. Scan in a lateral to medial fashion to visualize the hypoechoic transverse thoracic muscle lying deep to the intercostal muscle and superficial to the pleura. The pectoralis major, the intercostal muscles, the ribs, and the pleura are identified and traced medially towards the sternum until the transversus thoracic muscle comes into view lateral to the sternum and deep to the internal intercostal muscle as a hypoechoic band. The internal thoracic artery is identified in this plane between the internal intercostal muscle and the transversus thoracic muscle to avoid vascular puncture and intra-arterial injection. The internal thoracic artery runs between the internal intercostal muscles and transversus thoracic muscle and should be visualized prior to block placement. A closer look behind the sternum shows that the internal thoracic vein runs parallel to the internal thoracic artery and is also between the internal intercostal muscle and the transverse thoracic muscle. Vascular injury to the internal thoracic artery or pleural puncture can be avoided with appropriate in-plane needle advancement technique and vascular identification using color Doppler imaging. Place the ultrasound in the transverse orientation over the plane of interest in order to identify the artery by a longitudinal orientation of the ultrasound. This video shows the ultrasound imaging of the internal thoracic artery. And here is another scanning sample of the internal thoracic artery. In addition, the internal thoracic vein can be visualized at the same time. Identify the pleura. Here again, the sagittal cross-section view lateral to the border of the sternum, showing the pleura with the above transverse thoracic muscle. This cartoon represents an ultrasound image. B-lines will also help to identify the pleura. In addition, the pleura can be identified on an ultrasound by its characteristic lung sliding movement, when the pleura will seem to slide back and forth during breathing. After identification of the pleura, a blunt tip echogenic needle is inserted in plane to the transducer with bevel up. To ensure a constant visualization of the needle and to prevent pericardial puncture, the needle is advanced in an in-plane approach from caudal to cranial direction. Let's look at the needle insertion on a transverse cross-section view. Paracini et al. Described a distance for needle insertion of approximately 5 cm lateral to the sternal border at the level of the fourth rib to perform a TTP block. This is in contrast to the pin block, which is performed over the second and fourth rib with a scanning distance of about 2 cm lateral to the sternum. The needle target will be the transversus thoracic plane, which is between the internal intercostal muscle and the transverse thoracic muscle. Let's now look at the sagittal parasternal view lateral to the border of the sternum, showing the needle target directed to the transversus thoracic plane. This longitudinal ultrasound image shows the anatomy of the transversus thoracic plane before injection of local anesthesia. Moving the inferior rib off the screen ensures that the needle inserted in an in-plane approach is deep enough to enable the needle tip to reach the plane without bending or being placed beneath the superior rib, where because of the acoustic shadow of the rib, the needle tip cannot be visualized on ultrasound. After negative aspiration, correct placement in the transversus thoracic plane is confirmed with 1 to 3 mL of sterile saline via hydrodissection. Then local anesthetic is administered in 5 ml aliquots with intermittent aspiration every 3 to 5 mL to ensure that the intravascular placement of the needle tip has not occurred. Injection of local anesthesia into the transversus thoracic plane will result in a downward movement of the thoracic plane, the transverse thoracic muscle, and the pleura. This longitudinal ultrasound image shows the anatomy of the transversus thoracic plane highlighted in red before injection. This ultrasound image shows the injection into the transverse thoracic plane filling up with local anesthetic solution with downward displacement of the thoracic plane, the transverse thoracic muscle, and the pleura. Let's view the injection phase of local anesthesia from the transverse cross-section view. Injection into the transverse thoracic plane will result in a downward displacement of all structures below the transverse thoracic plane. So again, in a sagittal parasternal ultrasound, it looks like this, or like this on another ultrasound image. Please keep in mind that after injection of local anesthesia, the transverse thoracic muscle is located below the transverse thoracic plane, which is filled up with anesthesia solution. This real-time ultrasound video shows downward displacement of the pleura during injection, which confirms correct deposition of local anesthetics into the transversus thoracic plane. So here again, the right shot at the right place, leading to the right block. After block completion, the patient is closely monitored for 20 minutes for local anesthetics toxicity. Finally, I want to express my gratitude to following persons and institutions for kindly granting me permission to publish their figures. To the staff of the American Society of Regional Anesthesia and Pain Medicine, ASRA, and to Dr. Joanna Blair de Haan and co-workers, to Dr. R. Blanco Solado from anatomylearning.com for granting me permission to use their 3D Anatomy Atlas online, to Dr. Sajuri Fuji and co-workers, to Dr. Oliver Jones from Teach Me Anatomy, to Dr. Philip McCare and co-workers, and to the New York School of Regional Anesthesia NISORA. Also thanks to Bernard Rembarane and Dr. Guillaume Byland for their assistance during the shooting of the video clips in the OR. And here are the references which I used for this presentation. I wish you all success for the Transversus Thoracic Plane Block.